As a surgical oncologist, cancer is a disease that's particularly important to me. I know the fear that a cancer diagnosis can bring. I have also seen the power in what the right care team can achieve alongside you and your loved ones. We want to assure you that the hope and healing that you experience at Mayo Clinic is our top priority. Thank you for believing in Mayo Clinic Cancer Center's bright future in finding new cures and connecting to more of those who need us. Most importantly, thank you for trusting us with your and your family members' care.
Good morning, everyone. Welcome for today's session in Living with Cancer Symposium. My name is Parminder Singh. I'm one of the medical oncologists, consultant medical oncologist here at Mayo, Arizona. My areas of interest and expertise is genitourinary cancers. So I see patients with kidney cancer, bladder, prostate, and testicular cancer. With me joining today is Dr. Mark Tyson. He's an MD, MPH, attending urologist, associate professor, who is an expert in robotic resection of bladder cancer and prostate cancer. And he also takes care of patients of testicular and kidney cancer who need extensive surgery. And also our moderator today will be Dr. Charles Gollin. He's our fellow in oncology. He has joined us after finishing his training from Memorial Sloan Kettering and is going to be an aspiring and a successful oncologist in near future. So we'll start the session today. The session would be divided into two sections. In the first section, we'll have our moderator, Dr. Gollin, ask me and Dr. Tyson a few questions regarding kidney and bladder cancer and maybe some prostate cancer questions. And then he'll also take in the questions the audience is putting into the Q&A section and moderate those questions to us, and may also ask a follow-up question if he thinks that would make sense for our patients. So we'll start the session, and feel free to add your questions to Q&A box under your screen. And then we will address those questions as we come close to end of our presentation. So I'll let Dr. Gollin take over.
Good morning, everyone. Thank you for joining us. I would like to get started. I think our first topic for this morning will be bladder cancer. And there are a few things that I would like to address, and I wanted to talk with Dr. Singh about the role of immunotherapy in bladder cancer. Immunotherapy is a hot topic, as I'm sure all of you patients know, especially in bladder cancer. And talking a little bit about the differences between immunotherapy and other types of drugs might be helpful. I was hoping that Dr. Singh could shed some light on that topic.
Yeah, so thank you, Charles, for that question. This is a very important question, and is also of interest, since a lot of media attention given to immunotherapy because of the success of immunotherapy in a variety of cancers in the last few years. And recently it's been explored and now been approved in bladder cancer. So I do want to give you a basic understanding, or I'll explain you how immunotherapy works in prostate cancer. In a way, I try to explain to my patients when they come to my clinic. And so just for the background, I'm going to try to see if I can share my screen so that I can just have a cartoon behind what I'm saying, speaking. This way, you'll be able to understand. Let's see if you all can see my screen here, which says immune checkpoint inhibitors. Is it showing up?
Yes, we can.
Perfect. So, I don't want you to follow this, but just let's look at the colors to give you an understanding of what is happening inside and how immune therapy works for any cancer, in fact, not just bladder cancer. So we have immune cells, which are these purple and the orange and the white color cells. These cells are broadly called as APCs or CD4 or CD8. The purpose of these cells in controlling cancer process in our body is that they go around and check every cell of our body maybe every moment or every day, and looking for any kind of signal which suggests that a cell has gone rogue or have become cancerous. Now, once that happens, then these immune cells are obligated to go after and kill that cancer cell so that the cancer process doesn't progress. And if you see on the right side of the cartoon, you see that these orange color cells are interacting with these blue cancer cells with these protein signature interaction. When these interactions are happening, these interactions will signal the immune cells that these cells have gone rogue and they need to be destroyed. At the same time, there are proteins. I don't know if you can see this, PD1 and PDL1. These proteins are present on the surface of all cells, including cancer cells. And these protein signatures, the role of these signatures is to tell the immune cell that this is not a bad cell or this is a normal cell, because this interaction is happening not just with the cancer cell but with normal cells too. So the normal cells will give a signal to the immune cell using PD1 and PDL1 and tell them that this is a normal cell and it should not be destroyed. Now, since the cancer cells come or originate from the normal cells, they may carry these signals in the process of transforming into a cancer cell. And if that happens, when the immune cell will come to the cancer cell will present this signature to the immune cell, and the immune cell may decide to ignore the cancer cell and let it go and progress and metastasize. And that is what happens when somebody develop the manifestations of the cancer process. Most of us are developing cancers all the time, and our immune system get rid of these cancer cells. But when that escape happens, when this interaction is happening, when the cancer cell is able to tell the immune cell not to destroy me, that's when the cancer process will grow and spread. Now, once we understood that this interaction is happening, and we could very quickly figure out more proteins or antibodies, which we can inject into patients, and these antibodies will go and block this potential interaction. These antibody will not let PD1 or PDL1 interact. And if that happens, then the cancer cell is not able to tell the immune cell to not destroy it. And then if we are successful in doing that, then the immune cell will consider the cancer cell as a rogue actor and will destroy it. And that's how immune therapies came into use of cancer treatment. It was also the reason for the Nobel Prize last year, and the discovery of these medicines. And so they have significantly changed how we see cancers and how we treat cancers. Patients with bladder cancer, lung cancer, a variety of hematological cancers, we are seeing remarkable responses. We have not seen that kind of responses before. Just to give you an idea, this is one of our research pictures here. You see a patient who had extensively treated and now was progressing with bladder cancer here in the abdomen. After getting one of these immune therapies, the cancer completely responded. So that's how these medicines are changing how we take care of our patients. But at the same time, they are not a home run. Why I say that is because only 1 out of 5 or 1 out of 6 patients will have this kind of response. Most of the patients, the cancer cells may still continue to escape the immune environment because of other protein interactions. And that's the reason we are continuing to investigate different immune therapy strategies in these cancers to figure out better ways to treat. And that's where we at Mayo Clinic and other institutions are doing a lot of clinical trials to understand how we can augment the response we see with immune therapy, and improve care of our bladder cancer patients. Clearly, these medicines are easier to take versus chemotherapy, and they have their own set of side effects to deal with, but generally very easy and easier to take in terms of medications for cancer.
Thank you for sharing that with us. I think one of the main questions that individuals will have with respect to immunotherapy is, how will I feel when I'm taking it? You just mentioned that they're usually well tolerated, and they have a different set of side effects. But chemotherapy tends to be thought of as something that causes nausea, vomiting, sometimes hair loss. Is this used on its own? Is it used in combination with other chemotherapies? How will I feel when I take this medication?
That's an excellent question. So as these medicines were explored initially in bladder cancer specifically, these medicines were explored by themselves. And they were given to patients who had progressed. The cancers have stopped responding to chemotherapy, or they were not responding to chemotherapy. And they were given as a single agent at that time. So these medicines are given as infusions as you would receive chemotherapy. But then since these medicines are not traditional chemotherapy, they are not cytotoxic or what we call poisons. So they don't induce nausea, they don't induce vomiting or hair loss or diarrhea, the kind of symptoms we expect from chemotherapy, immunosuppression, decreased blood counts. And so you won't see those kind of side effects. On the other flip side, it is easier to take them, but then they can cause certain type of autoimmune side effects. These medicines can boost your immune system to then go after your normal cells also, in addition to the cancer cells. So if the normal cell going to be a liver, so then it can lead to inflammation of the liver. If it's going to be a lung tissue, then it could lead to lung inflammation. We call it pneumonitis. It can lead to inflammation of the gut, so it may cause inflammation, gastritis or colitis, which could present as diarrhea. But less common to have severe decrease in blood counts, causing infections or risk of infections or nausea or vomiting. And so these medicines, as I said, work in few patients, and also these side effects occur in few patients. So most of the patients will not have any problems. But then if somebody develops any kind of an autoimmune reaction, then we suppress the immune system back down by giving steroids, which are immunosuppressants, and that tends to take away these problems very quickly.
Great, thank you very much. I think another concern that comes up often with our patients with bladder cancer and other cancers are, do you expect me to be able to continue to work while on these types of therapies? Oftentimes individuals want to understand really the impact of treatment on their daily life, and often working is a priority for them to counteract some of the financial challenges that can come about with dealing with cancer. In your experience, do you see patients continue to work while on treatment for bladder cancer?
So that's a very good question. And with current insurance scenario, it is very critical that we try to keep that financial component of the care in mind. Certainly, these medicines are very expensive. You need to have good insurance coverage, which could cover these medications. But broadly speaking, most of the medications we use for bladder cancer are generally tolerated well, so that the patients will take time off during the days when they are coming in for treatment, and maybe a few days after. And then once the acute effects of the treatments are settling, we ask patients to, if it is possible, they should go back to their work intermittently during these treatments. This way, they stay engaged. They have a positive mindset as they're contributing to their work, and also able to maintain their insurance and able to continue with the treatment. However, some patients may develop some severe side effects, which we see, and then in that situation, we have them take time off, so that they can get through the treatment.
Great, thank you. Just a question just came in through the chat box. about essentially being able to modify the genetic makeup of cancer cells and change thereby their expression of certain antigens on their surface to allow them to respond better to immunotherapy, for example, or other antibody therapies. Are you able to comment on any of these modalities that might be studied currently?
Yeah, so very good question. I'm sure person who is asking is reading the literature closely regarding how we are trying to improve the effects of immunotherapy. So certainly, as these medicines were approved, we started to figure out that these patients who are responding are less. So we need to explore strategies to improve the response rate of immunotherapy. And we are now realizing that combining these medicines with either chemotherapy or radiation can help improve responses, as chemotherapy and radiation may improve or increase the expression of PD-1 and PD-L1 on tumor surfaces. And then we give them the immunotherapy, and that can help improve the immune response. So that is one strategy. We are looking at combining immunotherapy with chemotherapy and radiation. And I think you asked Charles before that if these medicines are given by itself or in combination. So the newer trials are coming up and showing that when we combine immunotherapy with chemotherapy, we are seeing better responses. And so we, in our practice, have now started combining immunotherapy with chemotherapy for certain indications, and we are actually seeing good responses in cancer patients. So that is one. And then the second is the genetic makeup of the tumor. Um, yeah, certainly bladder cancer. We have tried to investigate and see what genomic alterations are seen in bladder cancer. And 2 years ago, we realized a new drug called erdafitinib was approved, which targets the FGFR3 pathway. I didn't put up that slide here in my presentation, but it's basically a mutation in the tumor cell, so DNA alteration, where a certain protein or a pathway is overexpressed, and then we have this medication which can block this pathway, and then lead to quick response in the cancer volume. The cancer cell starts to die and they shrink, and we can control the cancer for further long. And these are patients who have already received chemotherapy and immunotherapy before. And so certainly genomic alterations and also newer strategies to improve immunotherapy are under investigation, and the early results suggest that there is a role, and we are trying to bring that into our clinical practice, but still more investigation needs to be done. And we certainly promote patients' enrollment on clinical trials exploring these strategies.
Great, thank you. Okay, if Dr. Tyson would like to weigh in on some of these strategies with respect to bladder cancer, I think many patients, when they are first diagnosed with bladder cancer, one of the things that comes to mind is what are my surgical options, and after surgery, what are the options for passing urine? Certainly, there are a few different options available, and patients may have heard about things like a neobladder or ileal conduit. And I was hoping, Dr. Tyson, if you'd be willing to share with us some of the differences between the different options and what's available out there.
Yeah, thank you, Charles. I think that, first, our priority is to save the bladder when we can. So the vast majority of patients probably in this room who have bladder cancer at one point or another started with a history of non-muscle invasive bladder cancer, because most people have non-muscle invasive disease. So in those instances, we try to do a lot of intravesical therapy that we stick into the bladder itself to help the immune system and other sort of patient factors fight the cancer locally. If the cancer progresses through some of those chemotherapies and BCGs and those kinds of things, then we often, in an effort to save the bladder, will then start to think about immunotherapies that Dr. Singh was just talking about, as well as other clinical trials that patients would have available to them for one more sort of effort at keeping the bladder. We have to remember that a lot of these non-muscle invasive bladder cancers are still very high risk, and many of these patients, when they progress through these treatments, will ultimately require removal of their bladder if they're looking to beat the disease long term. But let's say that you've arrived at that point where you need to have the bladder removed, whether it's for a refractory non-muscle invasive disease or newly diagnosed muscle invasive disease. The question then becomes, well, how do you do it, number one, and then what happens to the urine afterwards, number two, and are there any other options, number three? Those are the kind of three things that I cover when I talk to patients. And what I tell patients is that even though I'm a robotic surgeon, and in fact, I don't even think of myself as a robotic surgeon, just a surgeon, I'll do some open, I'll do some robotic. No matter which of those you choose, you're ultimately going to have a good outcome either way if you're going to a high volume kind of experienced place. It doesn't matter if it's done robotic or open. There are a couple of sort of nuanced benefits of having it done robotic, and there are a couple of nuanced benefits to having it done open. On balance, I do it robotic because that's my preference when I can, but there are times, like I said, when I prefer to do it open based upon patient risk factors. So I wouldn't, if I was a patient, fixate on the approach open versus robotic. More important thing I think to consider would be urinary diversion. And so if you are going to have your bladder removed, obviously the kidneys have to drain somewhere. I'm a big proponent of something called orthotopic bladder substitution. It's a long word to say neobladder, a new bladder. We take a long piece of bowel and I detubularize it. I form a sphere with that. I connect that down to the urethra, and then I connect the kidneys into that. All of the hardware, if you will, or the plumbing is on the inside, and that's attractive for a lot of patients. The functional outcomes for neobladders are good, but not great. It takes time for patients to learn how to use their new bladder because, again, it's small bowel, it's not bladder. And so the neurological and spinal cord reflexes that one has with their native bladder are absent. And so some patients in the short term will deal with incontinence and especially at night. But most patients who have neobladders are actually very happy. They get to a point where they're continent during the day, and they have a workflow at night, whether they urinate before going to bed or putting on a diaper or fluid restricting, those kinds of things. So neobladder outcomes are pretty good, and I'm a big believer in patients who are good candidates for neobladders. I think they should get it. There are some patients who are not a candidate for it, patients who have disease in the urethra, or patients who are frankly pushing 80, 85. That may not be the best person for a neobladder. That sort of age group tends to have more incontinence and tends to have more issues, and in some ways a simpler solution is just to do an ileal conduit. So that's a smaller segment of bowel that is not detubularized. You just keep it as like a conduit, like electrical conduit going on your roof, taking electrical wires from your panel to another part of your house. It's a conduit that delivers urine from the kidneys to the outside of the body, to the skin, into a bag. It's disfiguring, and so patients don't like it because of that, but it's actually highly functional. Most patients don't really notice a difference after a few months, and they get the hang of it. Nobody knows it's there. Nobody hears it. Nobody sees it. Nobody smells it. Basically, you can do anything that you were doing prior to surgery, after surgery, within one notable exception of maybe, kind of swimming with your shirt off if you want to keep it hidden. Most people would swim with their shirt on. That's basically the only thing that one can't do. And so the functional outcomes for both are good. It's an individual decision. When you sit down with a urologist like myself, it should feel like a conversation about the pros and cons. If it feels like somebody is telling you one is really bad and one is really good, then that's not an unbiased, objective assessment of the outcomes. An unbiased objective assessment of the outcomes would lead one to say, well, there are reasons to consider both. The third thing that we usually talk about is, well, do we have to remove the bladder altogether? Can we do something like radiation therapy to preserve the bladder? And the answer to that question is absolutely. Radiation is a good option for the appropriately selected patient. Generally speaking, they tend to be folks that don't have disease in the bladder, neck, and urethra. They don't have disease causing obstruction of the kidneys. They don't generally have sort of the high risk variant histologies. If somebody has sort of run of the mill, sort of routine early muscle invasive bladder cancer, and we frankly think we kind of resected it all during the TURBT, and they want to consider radiation therapy, that's reasonable. You can also use radiation therapy in patients who have advanced disease for palliation. So radiation has a role. As a surgeon, I tend to view things through a surgical lens. We know that there are some cancers that don't respond to radiation, but surgery tends to sort of force all the tumors to comply, if you will. So I think it's a consideration, and it's a discussion that you should have with your doctors in a multidisciplinary fashion, and something that you should consider. The things that I would add, though, about radiation, surgery obviously has a lot of downside risk in terms of perioperative complications, and downside risk in terms of long-term complications with incontinence and erectile dysfunction and all those kinds of things that we talked about. But so does radiation. Remember, when they radiate prostates, for prostate cancer, they're trying to avoid the bladder because of the toxicity that radiation causes to the bladder. Well, now with bladder cancer, we're aiming the beams directly at the bladder. And so there are a lot of patients who have a lot of overactivity, irritative voiding symptoms, frequency, urgency, bleeding. The bladder capacity over time usually gets smaller and holds less and less urine. And so I think of radiation therapy as just one of the options that are reasonable for patients who are open-minded and kind of considering all of the options.
Great, thank you so much. I think a little bit as a segue from our discussion about systemic immunotherapy, I remember, as a medical student learning about how a vaccine that was used for tuberculosis and its role in stimulating the immune system to fight cancer in the bladder as being something just fascinating. And that of course is the BCG vaccine. I know some patients will have that modality offered to them, and it tends to work well in most situations. However, it doesn't work for everyone. And I was hoping you would be able to shed a little bit more light about the use of BCG in bladder cancer and other options that are available when patients don't respond to this kind of therapy in non-muscle invasive bladder cancer.
Yeah, thank you, Charles. It's really a hot topic right now for patients who have newly diagnosed non-muscle invasive bladder cancer that's high risk of recurring or progressing. So that generally tends to be patients with stage 1 cancer, or patients with carcinoma in situ, or patients with high volume, high grade non-invasive disease. Those patients tend to be at high risk of recurrence. And so to the extent that we can lower the risk of recurrence and the risk of progression, then we'll achieve those goals that we talked earlier about saving the bladder and preventing morbidity or death from this disease. BCG is the best way for those patients initially. It's the best first step. We've been using it for decades. In fact, BCG has been studied since the late 19th century. In the late 19th century, we discovered that tuberculosis was infectious. 2 French immunologists started studying BCG as a vaccine in the 1920s. They started using it as a vaccine for children. It was a highly successful vaccine program. There were a couple of bumps in the road, but since then, we've been using it to vaccinate children in regions across the globe that are endemic with tuberculosis, and it works well for that for about a decade. In the 1970s, a Canadian urologist had the idea of putting it, just the vaccine directly in some saline and putting it in the bladder. It was based upon some data out of Memorial a couple of decades prior in the 1950s. It suggested that it had some anti-cancer properties. And so the question was, can we use this for high-risk non-muscle invasive bladder cancer? And there was a signal. And so a signal enough to convince 2 large groups to study it, SWOG and another group out of New York studied BCG. And there were two strains at the time, one produced by Merck, one produced by Sanofi. And that led to an FDA approval in 1991 and 1992, respectively. Both of those agents have been licensed in the US for commercial use since the early 1990s and been used extensively for that purpose, essentially since the 1980s. But in 2012, the Sanofi manufacturing plant had some FDA compliance issues and stopped supplying the US markets. They went on to supply the Canadian markets for another 6 or 7 years and then eventually got out of that market altogether as well. So Sanofi, who's I believe the largest vaccine manufacturer in the world, is not producing this vaccine. Merck is the only supplier of this drug. Over the last 6 years, it's led to some pretty significant shortages of the medication. In the last 2 years, it's been quite bad, to the point where, we order, 100 vials a month, for example, and we'll only get 10 or 15 sometimes. And so we have to ration the drug. And that's a shame because it works so well. 70+% of people will have a response to this medication. So we've been enrolling patients on a cooperative group study through SWOG. It's almost completed, essentially studying the Tokyo version of this medication versus the American version, and we're hoping to get another source of this drug in the US sometime over the next few years. Merck did just announce a major construction project that will improve their capacity by about threefold, evidently. But I think even with that, there's still going to be threats to the supply chain. Namely, there's one manufacturer. The stuff is hard to produce. The supply chain could go down from any, so multiple angles. Even JBL, that produces the Tokyo version of this, has had manufacturing issues, several of them over the last decade. So there's still going to be threats to the supply chain, but hopefully there'll be more BCG available, and you won't come to your doctor and hear, I'm sorry, we don't have any, but here's some chemotherapy instead, which is what we often have to do in the setting of the shortage. So, but let's just talk for a moment to answer your second question about what we do if a patient's able to get BCG but doesn't respond to it. In that setting, we have a lot of options. If somebody is young and healthy and they have invasive disease, so they're stage 1 disease, and they have really high risk features, oftentimes the best option is to remove the bladder. And a lot of patients don't like hearing that, but in terms of this cancer, it's an aggressive cancer, and it's often the best strategy for disease that it's unresponsive to BCG. The other options are immunotherapy, like Dr. Singh had said. Pembrolizumab was FDA approved this year for the use of BCG unresponsive disease, which again is defined as a patient who has a recurrence relatively quickly after receiving at least one 6-cycle induction course of BCG plus at least one 3-cycle maintenance course of BCG. If they recur early after getting that, then we consider them to be unresponsive to BCG, and they would qualify for pembrolizumab or Keytruda. The downsides to that are, we think it's a localized disease and you're giving a systemic agent. So, with pembrolizumab, as Dr. Singh mentioned, there are systemic side effects. And so that's not attractive to some patients. It usually requires a medical oncologist like Dr. Singh. So we usually get them involved, but there are some additional agents coming down the road, particularly too in the viral gene therapy space that are intravesical. Adstiladrin is supposedly going to be FDA approved any day now. I think there was some issues on the FDA side, just some administrative issues that they're working through. But there's another viral gene therapy essentially where we instill it into the bladder, and the virus is able to incorporate genetic material into the host genome to allow production of interferon gamma, which we think is going to boost the immunological effect of BCG. There's a couple of others that are in clinical development as well. There's chemotherapies that we can put in the bladder. Gemcitabine in combination with docetaxel tend to be popular choices. Valrubicin actually carries an FDA label for BCG refractory non-muscle invasive bladder cancer. It's expensive and the response rates are impressive, so we don't tend to use it all that often. But there's a lot of things that one can consider in this space, and it's an individual thing. Sitting down with a urologist and saying, hey, can you look at my history? Can you look at my comorbidities, and what do you think is going to be the best option in this scenario?
Great, thank you so much. There were a couple questions that came in through the chat earlier, and I think Dr. Singh, you might be able to shed some light on these topics. The first question was regarding CAR T cell therapy. And I guess it's trying to address to see whether there's a role for this in bladder cancer or if it's being studied. Do you know anything about CAR T cell therapy and its potential uses in bladder cancer?
So, yeah, so that's an interesting question. So CAR T cell therapy is the next generation of immune therapies which are coming into the space for cancer treatments. I'll just give you a brief because it's kind of a more, there's a lot of technological aspect to it. So bottom line is these are engineered T cells to target special antigens which are produced on cancer cells. Now, this kind of strategy works very well if the antigen is only expressed on the cancer cell, is not expressed on other normal cells. And that's where the success of CAR T cell was in the initial stages is more so in the hematological cancers where the cancer cells of the blood or the immune system, where these cells have specific antigens which are only seen on that particular type of cancer cell. In contrast, the solid tumors, like bladder cancer is called solid tumor because it comes from tissue. The proteins which are expressed on solid tumors are also concurrently expressed on other normal tissues, which then puts patients at risk receiving therapies targeting those specific antigens of getting more bystander side effects, where the immune cells may even then go and target the normal cells with the same degree, same intensity, and may cause severe harm, so much so that the patient may succumb to the side effects of the therapy. And so we are still in the early stages of development as we are trying to find better targets which are more specific to the cancer cell. So for example, there's a new drug which was approved earlier this year in bladder cancer space called enfortumab, which is an antibody drug conjugate. Basically, it's a protein which is carrying a payload, you can say, or chemotherapy, and is delivering that payload directly to the cancer cell. Now, the researchers were able to find a protein called as Nectin-4, which is expressed in most of the bladder cancer patients, but is also expressed on other tissues like skin, but more predominantly on the cancer cell. So they were able to create this antibody and attach a chemical or a poison or a chemotherapy to it to deliver. So I have a cartoon to share that. Let's see if I can share that screen again. Let's see. So can we see this cartoon here?
Yes, we can.
Perfect. So you see this is a green is the antibody, and the red is the chemical which is attached to the antibody, and then the antibody delivers the chemical to the cancer cell, and it attaches to this orange protein. Once it attaches, then it triggers a system where this whole complex is taken into the cancer cell, and then inside the cancer cell, the protein is degraded, is eaten up, and it releases the red chemical into the cancer cell, which destroys the dividing proteins which are important in dividing the cancer cell. So once the cancer cell divides from 1 to 2, in that process is disrupted, leading to cell death. Now, again, so this protein is expressed in bladder cancer, but it is also expressed in skin, and so we see a lot of skin toxicity with this. And so these, even though these cancer cells, we are targeting this cell, we also are putting patients at risk of toxicity, and we have to monitor patients closely. So similarly, in the CAR T space, we are not at a point where we could figure out the best target. There is ongoing investigations, and Mayo Clinic is in process of opening clinical trials. Because of the COVID, we lost 8-9 months of planning and exploring newer clinical trials. But now we are back into speed, and we are reviewing the portfolio of trials looking in of CAR T cells in variety of solid tumors. Yeah, but in bladder, we are still in a very early stage. We are still trying to figure out what should be the best target. So CAR T has not yet consolidated gains in solid tumor as much as it has done in hematological malignancies. And the reason I said is because of the lack of a target which is just present on the cancer cells versus normal tissue. Um, Charles, go ahead.
Thank you for sharing that. I think another question that came into our Q bank was with respect to determining, I guess, the risk of recurrence and the probability of cure after remission from treatment for bladder cancer in 5 or 10 years. The question was asking whether or not there are algorithms that were designed to determine this in patients who have bladder cancer.
So yes, broadly speaking, when somebody we see with bladder cancer or for any solid tumor, there are algorithms to outlay a plan of follow-up of how we are going to follow the patient once we achieve remission, to see in case in future they recur, and then we treat them. And usually those algorithms go out to 5 years. There are certain group of patients who are at higher risk of recurrence versus the other group, especially patients who have some kind of genetic alteration, or they're in some kind of inherited syndromes like Lynch syndrome may put patients at risk for upper tract urothelial carcinoma. So these patients may be at a higher risk for recurrence or developing a new cancer on the other side. And so these patients may require more closer follow-up. However, there are not any tests in a blood test, if you may say, or imaging modality which can tell us if the risk for recurrence is completely zero. Risk for cancer recurring in anybody who develops cancer will be higher than a general population, and the risk, however, goes down as we follow the patient, and the longer we are out from the time of diagnosis, the lower is the risk of recurrence. But I'm not sure if it goes down to zero. Dr. Tyson, would you like to make a comment on that?
Yeah, I agree. I think that's well said. I don't really have anything to add.
All right, so thank you. Just switching gears a little bit, I know Dr. Singh also cares for patients with testicular cancer, and I was hoping that you could share with us some of the risks for the development of testicular cancer and maybe some of the symptoms and things that can be looked out for in patients that are at risk for developing this.
Sure. So I think this question maybe Dr. Tyson would like to take out also, because he sees these patients as they present with testicular. I'm going to let him answer this question first, and then maybe I'll add.
Yeah, so obviously patients who present with testicular masses, there's a few things that we consider prior to removing the testicle. But that's obviously the treatment for the disease, the first step in the treatment. But patients usually consider sperm banking, and then they often will want a prosthetic. So that usually takes a couple of days to kind of arrange. But the treatment for that disease is going to be taking off the testicle, adhering to a few principles. It's done through a hernia incision, not through the scrotum. It's also done by taking the cord very high. And then what we do is we follow patients periodically with scans and labs that tell us if the cancer is active, and if there's evidence of the cancer becoming active, or if there's evidence of cancer being active at the time we first diagnose them, then we send them to patients to doctors like Dr. Singh, who can administer chemotherapy. And the chemotherapies in this space are so good. The patients that are diagnosed with this cancer are often young patients, and it's a devastating diagnosis to receive. But with Dr. Singh's help and with the therapies that he has to offer, the survival rates are very good. You don't need immunotherapy in this space because he cures everybody with the existing chemotherapies. So I would say that's the basics of testicular cancer: initial diagnosis and staging, and then what you could expect before seeing somebody like Dr. Singh.
Yeah, so I'll add to it in terms of risks and screening for testicular cancer. Um, Clearly, testicular cancer is a rare disease. So in the US, if you look at the numbers, maybe 9,000 patients or so a year are diagnosed with testicular cancer, versus somebody with bladder cancer or kidney cancer could be in 70,000 numbers, or in prostate cancer could be over 150,000 a year. And so it's a rare disease, but it is a common disease. In fact, it is the most common cancer in the age group of 15 through 35 in white Caucasian men in US. And so it is of importance because it affects a highly productive population and a younger population, and we need to take care of them quickly and also maybe predict risk in certain patients. So, for example, patients who had cryptorchidism, which means where when they were young, the testes have not descended into the scrotum prior to the birth, and they may require pulling the testes into the scrotum through a surgery. Those patients would be at a higher risk for developing testicular cancer on that side moving forward. So those kids or those young men would need to be followed or made aware of risk for cancer. The other reasons could be familial, or if somebody who has a prior history of testicular cancer on one side, that person would be at a higher risk of developing a cancer on the other side. There are certain race-related risks. So white men, as I said, are at a higher risk for testicular cancer. There are also certain phenotypes. So, for example, where the tip of the urethra is below the penis, we call it hypospadias. These patients may be at a higher risk for testicular cancer. But however, because the number of the patients, if you look in general population, is so low, that we don't recommend screening for testicular cancer. We don't ask men to go for regular screening for testicular cancer. But only in a high-risk situation where, as I said, we'll recommend that they may be followed closely by physicians, urologists, to detect these cancers early. As Dr. Tyson said, these cancers are highly curable, even if they're diagnosed in advanced stages. We more than 70% in the highest risk patients, we can get rid of the cancer by chemotherapy. In an earlier stage, if the cancer is detected early, then the cure rate is close to 99%. So very treatable disease, but clearly there is only a small group of patients who need to be monitored closely for it.
Great, thank you so much. And I was going to shift back to Dr. Tyson here and just was hoping for you to share some of your expertise with respect to prostate cancer, looking at the role of focal therapy in patients who have a new diagnosis of prostate cancer, and also maybe its use to treat cancer that's recurred after treatment. What's been your experience with these modalities, if you can share that with us?
Sure. Yeah, I think that a lot of patients are asking the question when they come in with a newly diagnosed prostate cancer: if the prostate cancer is only in one part of the prostate, why are you treating the whole prostate? Why are you removing the whole prostate? Why are you radiating the whole prostate? And for the appropriately selected patient, that's a good question. Patients who have low risk disease and very low risk disease, they don't need treatment, even focal therapy. In patients who have high risk disease and very high risk disease, those patients tend to be multifocal, and they're not a candidate for focal therapy because the disease tends to be multifocal. But if a patient has Gleason 7 disease, which is often the sort of the index disease that we consider for focal therapy, and they have a reasonable PSA, and they have a clearly definable lesion on the MRI that is biopsy proven to be the carcinoma, the Gleason 7 carcinoma, with virtually no cancer anywhere else, or maybe a little bit of Gleason 6 somewhere that we can put on surveillance. Those are patients that are good candidates for just treating that one area of the prostate. And the obvious upside to that is going to be preservation of function. Patients won't experience a loss of erectile function, sexual function, or urinary function. And not everybody's a candidate for it, and there are certain reasons why you wouldn't do it. But if somebody kind of fits that bill and they're interested, they could undergo something called Haifu or cryo. Haifu is what we do here at Mayo. It uses essentially energy to heat the prostate and to ablate that zone. We do it under real-time ultrasound guidance, but with fusion from the MRI. So we take the images that you have pre-op on the MRI, and we fuse them in real time with the images that we're getting on ultrasound, and we're able to ablate the abnormal region with a healthy margin around it. This technology, this particular technology, there are others, but this particular technology was FDA approved last summer, and I believe there's 9 or 10 places across the country that have the technology and that are doing it. So it's a really innovative approach. There are other ways to do focal therapy. The Europeans are light years ahead of us in this regard, and I think that in 10 years this will be a way that we're really thinking about treating this disease. It'll be a bigger part of how we treat this disease, and I think it's the future. But right now it's still in its infancy, and still can't look at patients and say, well, your cancer outcome is going to be as good as radiation, or your cancer outcome will be as good as surgery, because frankly, you're at risk of recurrence in the parts of the prostate that aren't treated. So that's what I would say is the basics of focal therapy and how we deliver that technology here locally in Arizona. But I think that there are other indications for using it, such as you mentioned, Charles, somebody's recurred after radiation, they have one little spot that, could you sure, absolutely. You could use it as a salvage setting. The data is probably better for the salvage setting anyhow. But I would say those are the basics.
Let me ask you a question, Dr. Tyson. So in patients like this, where you think they have a very localized disease, and you plan to do an intervention where you will not be attempting to remove the whole disease, cancer area, what is the risk of doing a biopsy in these patients? Would you not be spreading the cancer locally?
I get that. Yeah, I get that question all the time. And it's a really good question. It's a tough one to answer because we don't think that there is any risk of spreading the cancer with the biopsy with prostate cancer, but we know that is a small theoretical risk with, as you know, upper tract urothelial carcinoma. Very, very, very small. I mean, there's just a few case reports kind of thing. It's not a common finding, but it does seem to happen. In prostate, there's really no other way to diagnose the tissue. So patients say, well, will the prostate biopsy spread the cancer? And my answer to that is probably not. But there's no other way to know if you have cancer. So it's kind of it's a moot point. We're stuck in sort of a quagmire of not, paralysis by analysis. We have to make a diagnosis, and really the only way is to do a biopsy. It can be transrectal or transperineal, but either way, you're putting in a needle. With Haifu, though, I'd point out that there's no needles, there's no incisions, there's no violation of the skin or epithelium or the rectal mucosa. It's all done through sound waves, and so the probe is in the rectum, but there's no incisions or needles or biopsy. So hopefully there's no risk of the cancer spreading with Haifu itself.
Thank you.
Thank you. And both Dr. Singh, Dr. Tyson can probably speak to this question that just came in from the audience. This question was in relation to the use of peripheral biomarkers in the detection or monitoring of prostate cancer. Just asking about its role, and also maybe about its pitfalls as well, if one of you could comment on that.
Go ahead, Mark.
I'll comment maybe on the second half, and then I'll let Dr. Singh comment on the first half. So biomarkers in prostate cancer are a hot topic. We've been using PSA for a long time. When your oncologist tells you that the PSA is useless, he or she is right. For screening, PSA is not very good. An objective person looking at the data for screening would say there are legitimate trade-offs here that need to be considered for using PSA as a screening tool. It's not to say that we shouldn't do it. It's just to say there are trade-offs to consider. And so, I wouldn't say useless, but I would definitely say challenged. PSA has some challenges that as a screening program, that need to be considered. But there are other biomarkers that are emerging in this space, and it's a heavily funded area in terms of extramural research dollars. And Dr. Singh, I'm sure, can comment to a greater extent than I on biomarker selected treatment. So the publication of Profound. Dr. Singh, do you want to kind of walk through what role DNA damage repair genes have and other biomarkers that you see on the horizon?
Sure. So no, thanks for that. But I think we can come to that question of DNA damage repair mutations. But I think the question relates to truly to what other markers are there to follow or detect cancer or to follow treatment. And so, as Dr. Tyson said, in the context of screening, PSA value is challenging, but in a context of treatment monitoring or decision making, PSA is considered to be one of the parameters we consider when we are making a treatment plan. So to explain you further, so PSA trend is critical in a patient that I see, patients who have advanced disease, who have metastasized. When we give them treatment and the PSA falls down and patient is feeling better, and there are other blood markers which are getting better. So in that clinical context, the PSA gives us a sense that the treatment is working. And then once we have shown that in a patient the treatment is working, and then on follow-up, after some time, if the PSA starts to go up, then it may indicate that it's time that we may require treatment change moving forward in the care of the patient. So in that clinical context, when the patient's treatment and the PSA goes down, PSA is a good marker of indicating response. And then on treatment, if the patient had low PSA and then the PSA starts to go up, it indicates that now in near future there would be a treatment change which is coming. The absolute value of PSA may not help us make treatment decisions as much as the trend of the PSA or how fast the PSA is going up. And that's how we use this information in a more nuanced way. So it is not appropriate to use or look at PSA value as a number in one point time. It is used by us in a clinical context. And that's where there is a lot of confusion, there is a lot of anxiety, there is a lot of frustration that, oh, my PSA is going up and my doctor is not making a change, or my PSA is not going down as fast as I would expect, and my doctor is not making a change. Because this is all this information is used in a clinical context. And so the experts will use that information in that way. And looking at the other newer markers for detection and follow-up is something called as circulating tumor cells. So circulating tumor cells, a lot of investigation being done initially showing that if the number of the cancer cells, we can detect cancer cells floating around in our blood as we treat patients. And if the number of those cancer cells is going down, it may indicate that the patient is responding to treatment. If it is coming up, it may indicate that the patient is not responding to treatment. However, the earlier investigation, even though they showed that there is a correlation between response of these circulating tumor cells, the cost and the additional information this piece is adding to what all we already have was limited, that it didn't take off as we use PSA routinely. So the use of circulating tumor cells is highly limited only in certain clinical context. However, there is new research going on right now, and Dr. Tyson's team is part of SWOG 1802, which is a clinical trial looking at newer treatment strategies for advanced prostate cancer. And they have a full team of investigators, researchers. They are looking at circulating tumor cells. They are looking at circulating tumor DNA. They are doing whole exome sequencing. They're investigating newer markers to detect, monitor patients on treatment with advanced disease, which can be translated into a much better clinical outcome. So that could, I would say, better upon what PSA gives us the information, and may change how we see and follow patients in near future. But it is still 3, 4, 5 years from that point. But certainly, this is a good question. And I can touch upon, I know we are reaching end of the hour. Are we close to our time, Charles? Or
Yes,
we
I
have,
think so.
yeah,
Yeah.
okay. So we'll quickly address this last comment from Dr. Tyson regarding DNA damage repair mutations. So certainly this is a new era. We are getting new information. There are newer genetic markers. We look in prostate cancer patients, and certain patients whose tumor have DNA damage repair mutations, these patients or their tumor may respond to a class of medication called as PARP inhibitors. These are pills. These are not chemotherapies, and most of the patients will respond despite being progressed on chemotherapy and other treatment options for prostate cancer. So certainly a new drug in the armamentarium for our patients who have advanced disease, and we look for these markers in our patients now routinely. So go ahead, Charles.
Great. Thank you so much for taking the time to answer all of these questions, Dr. Singh and Dr. Tyson. I know we're coming close to our end time, and I think we've addressed most of the questions from the audience. Are there any closing remarks that you wanted to share?
Dr. Tyson?
Yeah, I think the session might actually go until 9:15, so I think we have a little bit of extra time. But I don't know if there's any more questions from the audience. I would just close by saying I think that these are heavy topics that we're discussing today, and a lot of people, as things, it's already very complex and disheartening to be told that you have cancer, and then there's these options for chemotherapy and radiation and surgery and all that. And now when you add in all the work that the scientists have been doing over the last couple of decades with, new drugs and new biomarkers, it's just so overwhelming. And that's what I would say is the value of coming and getting multidisciplinary input, seeing folks like Charles and Parminder and myself and folks on the rad-onc side, and having your cases discussed in a sort of multidisciplinary fashion, I think is really the best way to find what sort of options are ultimately going to be the most valuable to you individually, because everybody's different, everybody's cancer is different, everybody's function and comorbidities are different. And so all of that factors in when the decisions are made on the treatment side. So that's what I would say. I would encourage you to get multiple opinions from multiple service lines, and because it is a complex area. Dr. Singh?
Yes, no, thank you. I agree with you, Dr. Tyson here, that, when I see patients, I tell them that when we look at clinical trials and they look up data of how patients are responding, or what is the average lifespan of patients with a certain diagnosis, and that kind of gets them in their head that, it says, 3 months average lifespan. So we always tell our patients that Mayo Clinic, here we strive to keep you ahead of the curve. When you look at these averages, our goal here in a multidisciplinary way the care is provided here is to keep you ahead of that curve so that you beat the averages, because you have talent here who are scientists who look at the most latest technology to deal with cancer, and they look at most latest treatments. And then on top, you have access to clinical trials, which are state-of-the-art clinical trials looking at newer drugs, which may come to use in patients in next 3, 4, 5 years. So I always give an example of a drug, enfortumab, which I showed you the picture of the antibody carrying the drug. We have been using this drug in our patients for 3 years. And now only this year, the drug was approved. But all patients who were treated here, we had them on clinical trials, and they were able to get that drug, and they did so well, and that data then led to approval of that drug. And so similarly, if you are in a center where you have access to these newer clinical trials, both in surgical and radiation and medical oncology, then you have access to newer options which you may not have in a smaller clinic settings. And that's where we can then take you ahead of the curve and get you best outcomes for your disease.
So thank you. I know we didn't have as much time to devote to kidney cancer, but there was one question from the audience that asked about new research in that space that's been ongoing in the last, I guess, year or so. Would you be able to address any of these questions, Dr.?
Yeah, sure. So, kidney cancer, we in our clinic, we see patients who have disease which has spread to other parts of the body. The patients who have early stage disease, which is limited to the kidney, is usually seen by Dr. Tyson and his group. And the treatment is usually standard of removing it. However, there is newer technologies to deal with very small kidney masses, and there is always an investigation happening to understand whether these patients should have their half of the kidney removed or full kidney removed, or what is the best strategy for a smaller kidney mass. But on the advanced disease setting where the cancer has spread to other parts of the body, there has been a slew of new drugs which came out in last few years, and newer strategies to treat our patients. Clearly, how these medicines work and how they control the disease is kind of outside the scope of this talk because it is little complicated to explain. But to just give you an overview, we are now at a point where patients who had metastatic disease, kidney cancer, is now living longer and longer for many years, which means could be 4 or 5 years if treated aggressively in a more nuanced way, patient directed therapy in which we select patient for the right treatment in the right fashion and sequence these options in a right way. We can get many years in patients who have advanced disease. There are newer strategies combining immunotherapy with newer drugs, and also exploring newer targeted agents. So the space of kidney cancer treatment has kind of exploded and is nuanced. And so I would recommend strongly, if anybody, you or your family member are dealing with that problem, should explore an opinion from one of our kidney cancer experts who can then kind of set you a treatment plan to get the best out of this disease. So certainly a lot of new things happening in kidney cancer. Comments from you, Dr. Tyson?
Yeah, and I was just going to say, there are two types of kidney cancer, as Dr. Singh was talking about, and the type that we mostly think about is going to be that renal cell carcinoma. But there is another type where, as we talked earlier about immunotherapies and chemotherapies, that it's essentially the same type of cancer as bladder cancer, but it occurs in the kidney, or the tube that drains the kidney down to the bladder, and that's called upper tract urothelial carcinoma. And in those settings, when you have upper tract urothelial carcinoma, it's treated very differently than renal cell carcinoma, and it's treated more like bladder cancer. And the only point I would make about that is instead of just, for example, if you're going to surgically remove a kidney for renal cell carcinoma, it's a different operation than if you're going to surgically remove a kidney for urothelial carcinoma. So upper tract urothelial carcinoma requires the removal of the entire kidney and ureter altogether, and in even a little part of the bladder. So that's a different operation, number one. Number two, we often in those settings really push chemotherapy up front with Dr. Singh, because once we take the kidney out, there's oftentimes not the ability to give the chemotherapies that we need. And it's often the case that patients with that type of kidney cancer need those chemotherapies. And so we tend to proceed with upfront chemotherapy if you have that upper tract urothelial carcinoma. And lastly, I would say that if somebody has upper tract urothelial carcinoma, but they have localized disease and it's low grade or just a little bit of high grade disease, we do try to ablate those tumors endoscopically without removing the whole kidney. I would say the outcomes from that are good, but not great. It tends to be a multifocal disease. It tends to recur after ablation, and that's really just buying more time with the kidney itself. Dr. Singh, do you have anything to add about upper tract?
Yeah, no, so I agree with you that this disease in the upper tract setting is uncommon, but at the same time, it is a little difficult to diagnose, stage, and treat appropriately because of the small area. And experts like Dr. Tyson and his team are highly skilled of going and navigating their scopes up through the bladder into these tubes, which are very, very small and thin and few millimeter size, and try to get biopsies for us to then make treatment decisions based on those biopsies, which is very, very small amount of tissue. So it requires, and it takes many years to understand this staging, and then also to make the right treatment decision calls in patients like upper tract disease. But certainly, the role of chemotherapy is critical. And now with the newer trials showing combining immunotherapy and chemotherapy, we are taking this field further, improving upon the results of previous trials, and our patients are doing better and better, certainly.
Great. Thank you so much to the both of you. I know there was a point made by the audience about, the responsibility of learning about new treatments from the patient's perspective. And I think this does highlight the benefits that patients who seek care from specialized tertiary care centers, where oncologists have the opportunity to focus their treatment specifically, with respect to
Your
one
conference
area.
is scheduled to end in 2 minutes.
I think that that's certainly something that individuals dealing with cancer or who have family members who are dealing with cancer need to consider when pursuing treatment options. I know that our conference is rapidly approaching its end, so I'd like to thank all the panel members as well as all the patients and attendees to this conference for your interaction and your questions. We're certainly available to you as a resource and are happy to have had the opportunity to interact with you over the course of this session. We routinely have these sessions over a period of time, as mentioned earlier. If you have any other questions or concerns, please feel free to contact us.
I
Thank
agree.
you so much.
Thank you for having me.
Thank you.